Hello friends. So we keep asking about reticulocyte count in patients with anemia. For example, this case with hemoglobin 7.7 gram per deciliter, reticulocyte count was given as 1%. So how do we interpret this? Let's try to learn. So starting from some basics about reticulocyte. Reticulocyte is one of the terminal stages during the development of RBCs. So you can say that they are young or baby RBCs, which are released prematurely from the bone marrow into the peripheral circulation, where they take around a day to mature into a normal red blood cell. In normal setting, when hemoglobin is in normal range, they account for around 1 to 2% of all RBCs. We can say that around 1 to 2% of old and senescent RBCs are continuously replaced by these reticulocytes on daily basis. So reticulocytes actually derive their name from RNA reticulin, which you can see here, which when stained with the supravital dyes, they give an appearance of bluish cytoplasm in contrast to a mature red blood cell which has a central pallor inside it. On the right side, in the peripheral blood smears, you can easily distinguish these bluish cytoplasm reticulocytes from normal RBCs because these are blue in color. Secondly, they are relatively larger. And thirdly, they are fewer in number as compared to normal RBCs. So what is the significance of knowing reticulocyte count? It helps in differentiating between the decreased production of RBCs in bone marrow vis-a-vis increased destruction of RBCs in periphery. Or in simple terminology, you can say that it helps us to assess whether bone marrow is doing its job in anemia. So, for example, if reticulocytes are increased in the setting of anemia, it means it's an effective erythropoiesis and decreased production is not responsible for anemia here. Rather than we should search for causes of peripheral destruction of RBCs. Whereas if reticulocytes are less in peripheral blood, in the case of anemia, it means it is ineffective erythropoiesis and decreased productions of RBCs in bone marrow is responsible for anemia in this case. Now, how much adequate response of reticulocytes gives us clear picture whether or not bone marrow is responding to anemia. That can be calculated by applying two corrections to whatever lab value of reticulocytes is being given to us. And these two corrections are first for degree of anemia and second for reticulocyte lifespan. So we'll try to understand. The first correction is for degree of anemia to get corrected reticulocyte count. So we'll try to learn from this image where the left side of the image, that is left circle, gives us under the normal circumstances these light colored cells, let us call them as reticulocyte. They account for around 3% of all RBCs, so making it 3%. Whereas in case of anemia, the same reticulocytes count or reticulocyte percentage will be increased because there will be significant reduction in RBC numbers. So the same 3 reticulocyte counts here are accounting for 10% of total RBCs, which is artificially high, or you can say erroneously high, because it is a relative value. So to correct this artificially high value, we have to apply first correction to get corrected reticulocyte count. For example, in a case of hemoglobin of 7.5 gram per deciliter, hematocrit or packed cell volume of 22.5%, and reticulocyte count of 10% given by lab. So reticulocyte correction, that is first correction to get corrected reticulocyte count, will be reticulocyte into patient hemoglobin divided by normal hemoglobin, or reticulocyte count into patient hematocrit divided by normal hematocrit. In this case, 10 into 22.5, that is patient hematocrit, divided by 45, which is normal hematocrit, will give us a corrected reticulocyte value of 5%. The same we can calculate by hemoglobin also, because 10 into 7.5 divided by 15, we take 15 as an average normal hemoglobin, then also we'll get corrected reticulocyte count of 5%. Then we have to apply the second correction, that is because of reticulocyte lifespan, to get reticulocyte production index, what we were trying to calculate. Why? Because it mirrors the adequate response of marrow to the anemia. So as I said that reticulocytes spend 1 day in peripheral blood to mature into normal RBCs. But in setting of anemia, bone marrow starts or bone marrow races or compensates for this anemia and pushes these reticulocytes at a much earlier stages than in normal. So these reticulocytes will spend more time in peripheral blood to mature into normal RBCs. So initially or under normal circumstances, they used to take 1 day. Now they'll be taking much more time than what they used to take in normal circumstances. So we take that as maturation time and an average value of double the normal. So the normal was 1, so we take it as 2. And so reticulocyte production index is corrected reticulocyte count, which we got in our last slide, divided by maturation time, which has now doubled, so that we take an average value of 2. So 5 divided by 2 is 2.5%. So what this 2.5% is reticulocyte production index, which gives us a correct picture of marrow response in the setting of anemia. So again, revising, reticulocyte production index, that is RPI, will be calculated after applying two corrections. First correction for the degree of anemia. We multiply the lab reticulocyte count into patient hematocrit divided by normal hematocrit, that is 45, or patient hemoglobin divided by normal hemoglobin, that's we take it as 15. And to that corrected reticulocyte count, we apply second maturation correction, because now reticulocytes are spending more time in peripheral blood to become mature RBCs or effective RBCs. So we divide the corrected reticulocyte count by 2, because under normal circumstances, reticulocytes used to spend 1 day to mature into normal RBCs. Now we are taking that time as double the normal. So we are dividing the corrected reticulocyte by 2. And this will fetch us reticulocyte production index. So what is the significance of how do we interpret reticulocyte production index? RPI less than 2 indicates reduced bone marrow production of RBCs or ineffective erythropoiesis. That means bone marrow is not producing adequate amount of RBCs in the setting of anemia, and it has to be blamed for that anemia. But when RPI is more than 2, it means effective erythropoiesis. Bone marrow is compensating for that anemia. Bone marrow is responding adequately and cannot be blamed for this anemia. Rather than we should search for some causes of peripheral destruction or any bleeding. So what are the cases where we can get low reticulocyte production index? For that, we have to understand that an effective erythropoiesis will require 3 things. One is a healthy marrow. Second, an adequate supply of iron, B12 and folate. And third, a normal functioning kidney that should secrete erythropoietin, because that will stimulate the erythropoiesis. Disease of any of these three will result in decreased production and thus reduced RPI. For example, any kidney disease. Second, any reduced supply of iron, vitamin B12 or folate. That means any deficiency of iron, B12 or folate. Third, any disease of bone marrow. For example, infiltration of bone marrow by malignancy, leukemias, fibrosis, or any infection that will lead to reduced production and thus reduce or low reticulocyte production index. Whereas high RPI, that is high reticulocyte production index, is typically seen in hemorrhage, that is in the case of bleeding, or hemolysis, that is peripheral destruction. So now we try to interpret the same first case. That was our first slide. So hemoglobin is 7.7 with hematocrit, you can see 27. So here the corrected reticulocyte count will be somewhere about 1 into 27 divided by 45. That will be around 0.5%. And we have to divide it by 2 to get RPI. So naturally, RPI or reticulocyte production index will be less than 2. It means here the marrow has to be blamed for inadequate or decreased production of RBCs. Whereas, take this case, here also patient is having severe anemia, hemoglobin of 7.1% and reticulocyte of 12%. So we calculate the corrected reticulocyte count, that is 12 into PCV, that is 22.4 divided by 45. That will fetch us the corrected reticulocyte count of 6%, and that will be divided by 2, which is maturation correction. That means that will come as 3. So reticulocyte production index is more than 2 in this case. So marrow is responding very well. So this is case of peripheral destruction or bleeding outside the marrow, and marrow cannot be held responsible for this anemia. To conclude, reticulocyte count or derived RPI can help us in evaluating any sort of anemia, but it is more genuinely useful when we are not able to sail through the diagnosis of anemia with the help of MCV and RDW. That is, patients with anemia having normal MCV and normal RDW. There, a low reticulocyte will help us to know a diseased marrow, and high reticulocyte will help us to know that peripheral destruction or bleeding is taking place. And how do we differentiate between hemorrhage and hemolytic anemia? In hemorrhage, liver function test will be normal, whereas in hemolytic anemia, you'll have increased serum bilirubin with indirect fraction more than direct. I hope this will help you to understand and evaluate the anemia better. Thank you.